في أي أسئلة؟ شكرا.
السلام عليكم يا شباب. هنبدا السيشن بتاعت التوتال ني ريبليسمنت. المحاضره الاولانيه بتاع الفاندامنتال برايمري توتال ني الدكتور حسام ما قدرش يجي، عنده ظروف او السكه معطلته. هنبدا بالمحاضره الثانيه correction of surgical deformities in total knee replacement. الدكتور محمد مهران، اتفضل حضرتك.
شغال كده. بسم الله الرحمن الرحيم. أنا محمد مهران من جامعة أسيوط. طبعا بحب أشكر مستشفى الهلال، دكتور محمد عوض، دكتور وليد على الدعوة الكريمة. وهنبتدي التوتال ني أو الني ريبليسمنت سيشن. بحب بس أشكر أساتذتنا الأفاضل اللي كانوا في السيشن بتاعت الشولدر، لأن أنا I'm not a shoulder surgeon but I was very interested في السيشن اللي فاتت، فبشكر أساتذتنا اللي قدموا السيشن بتاعت الشولدر. I'm going to speak about correction of sagittal deformities in total knee arthroplasty. If you take a look at this X-ray, I think it's severe arthritis. I think this patient is like 60 years old or 65 years old. This is the other side. However, this patient is just 43 years old, and the cause for the severe arthritis is the recurvatum deformity. So, correction of the sagittal deformity in total knee replacement is very crucial and will improve the patient after the total patient lifestyle after total knee replacement. Our agenda today is to understand the biomechanics. Our goal, what do you want to achieve? General rules while doing your total knee, and how to manage different scenarios while you are trying your trials before putting the final implant. Understanding sagittal plane deformities. Of course, there is a difference between the knee in the sagittal plane and in the coronal or the frontal plane. because the knee doesn't have functional range of motion in the frontal plane. Therefore, there is no compensatory knee range of motion for mechanical axis deviation. Because the knee moves in the sagittal plane, the sagittal plane alignment of the hip, knee, and ankle changes with normal knee motion. يعني احنا كل ما بنحرك كده كل ما الميكانيكال اكسس بيتغير معايا، وده بيعمل compensation لو عندي deformity معينة سواء في التيبيا أو في الفيمر. The line from the center of rotation of the hip, center of the femoral head, to the center of the ankle is the mechanical axis in the sagittal plane. With the knee in full extension, this mechanical axis must come in front of the knee center of rotation, anterior to the center of rotation of the knee joint. This allows the knee joint to be locked in full extension, and locking of the knee in full extension will allow the quadriceps muscle to relax. يعني أنا لما باجي أقف كده ليه أنا بقف ما ببقاش مجهد؟ لأن خلاص السنتر اوف روتيشن اوف ذا ني راح ورا الميكانيكال اكسس ديفيشن، فبالتالي الكوادريسبس بقت ريلاكسد. لكن لو انا عندي فليكشن ديفورمتي انا علشان افضل واقف انا لازم هفضل عامل كده، فالكوادريسبس هتبقى continuously in contraction which will lead after some time to quadriceps fatigue. Moving the sagittal mechanical axis forward is an important compensatory mechanism in gait for the paralytic patients, example like polio or spina bifida. During gait, the hamstrings are responsible to prevent the hyperextension of the knee. So if you examine a patient while walking, you won't be able to notice the recurvatum deformity. But while standing, the recurvatum deformity will appear. Knee malalignment in the plane is better tolerated than in the frontal plane because hip, knee, and ankle will move in the sagittal plane and can therefore compensate for sagittal malalignment. We have in this a recurvatum deformity of the tibia, which is compensated by flexion of the knee joint, and a flexion deformity of the femur, which is compensated by hyperextension of the knee joint. So your goal is to achieve an equal flexion and extension gap through the whole arc of motion in the total knee or after total knee replacement. General rules: if you have asymmetry, if the flexion gap and the extension gap have asymmetric problems, you have to correct the distal femur cut or the posterior femur cut. If you have a symmetric problem, then you have to correct the tibial cut because the tibial cut affects both flexion and extension gap. Remember always that increasing the size of the femoral component will only affect the anteroposterior diameter of the femoral component. So it will only affect the flexion gap, but it will not affect the extension gap. Different scenarios you'll find during doing your trial before putting the final implant after total knee replacement. If you put your trials and you got your knee tight in extension and tight in flexion, what to do? You'll have to cut more proximal tibia. We all agreed that the tibial cut will affect both flexion and extension gap. If while doing your trial, you got a knee that's tight in extension and balanced in flexion, what will you do? You release more posterior capsule and osteophytes. This is number one, and always take care of the posterior capsule and the PCL. Number two, you have to cut more distal femur because the distal femur will affect the extension gap. If you get a knee that's tight in extension and loose in flexion, what to do? You have to resect more distal femur, which will improve the tightness in extension, and you have to upsize the femoral component. And we agreed that upsizing the femoral component will only affect the flexion gap because it changes only in the anteroposterior diameter. If you get a knee that is balanced in extension and tight in flexion, what will you do? You have many options. You can decrease the femoral component size, which is required an increase in resection of the posterior femoral condyle. Release and recess PCL, release posterior capsule, and recut proximal tibia with increased slope if you have the instrumentation right to do this. If you got a knee that is balanced in extension and balanced in flexion, what should you do? Nothing. This is the perfect scenario. You will do nothing if it's balanced in flexion and extension. If while doing your trial, you got a knee that is balanced in extension and loose in flexion and with a positive drawer test, what will you do? You can increase the size of the femoral component. Again, it will be affected the anteroposterior diameter only. And you can posteriorize the femoral component by putting augments and use a bigger size of the femoral component. If you got a knee that is loose in extension and tight in flexion, what will you do? You have to downsize the femur and use a thicker tibial insert, and again do your trial until both extension and flexion gaps are balanced. If you got a knee that is loose in extension and balanced in flexion, what will you do? You have to augment the distal femur. If you got a knee on your trial that is loose in extension and loose in flexion, what shall you do? Loosen both flexion and extension. What do you think we should do, young surgeons? We all agreed that the tibial cut will affect both extension and flexion gap. So you have to again increase your cut, not cut more. You have to replace what you have already cut. So you can add a thicker tibial polyethylene or add medial and lateral metal augments to the tibial tray. I know it's a little bit confusing, but just take it easy and you will be able to memorize it. So our take-home message: sagittal balance is crucial during total knee arthroplasty. It allows a near full range of motion, improves the stability of the polyethylene insert, and decreases the wear after total knee replacement, increases patient sense of security and satisfaction. And I think we still have time, so we can revise again. If it's tight, you do cut more proximal tibia. If it's tight in extension and balanced in flexion, you release posterior capsule and cut more distal femur. If it's tight in extension and loose in flexion, you resect more distal femur or use thinner distal femoral augmentation wedge, and you can upsize the femoral component. If it's balanced in extension and tight in flexion, you decrease the size of the femoral component, release the PCL, resect posterior slope in tibia, and resect more posterior condyle and release the posterior capsule. If it's balanced, you have to do nothing because this is the perfect scenario. If it's balanced in extension and loose in flexion, you can increase the size of the femoral component, which will affect only the anteroposterior diameter, and you can posteriorize femoral component by adding more augments to the posterior part of the femoral component. If it's loose in extension and tight in flexion, you downsize the femur and use a thicker tibial polyethylene. If it's loose in extension and balanced in flexion, you do augment the distal femur. If it's loose in extension and loose in flexion, you use a thicker tibial polyethylene and use thicker tibial metal insert or add augmented blocks to your tibial insert. Finally, I need to thank you all for your attention.
نشكر الأستاذ الدكتور محمد مهران على المحاضرة الشيقة.